Moving on to dengue. So dengue virus, dengue is the most common arbovirus found in India. It belongs to family Flaviviridae. Arbovirus, Flaviviridae. So arbi, it has a flavor, right? So Flaviviridae. It is an enveloped virus containing a single-stranded RNA. So it is named after the Swahili word dinga, which means fastidious or careful. So it has 4 serotypes, Den 1 to Den 4. All have been identified in India, and recently the 5th serotype, Den 5, was discovered in Bangkok, but not in India. So Aedes aegypti is the principal vector, followed by Aedes albopictus. They bite during the daytime. Anopheles bites during the night. So Aedes aegypti is a nervous feeder, so it bites repeatedly to more than one person to complete a blood meal, and it resides in domestic places, so it is the most efficient vector. Whereas Aedes albopictus, it is found in peripheral urban areas. It is an aggressive feeder, less efficient in transmission. So Aedes becomes ineffective only when it feeds on viremic patients. So Aedes can pass the dengue virus to its offspring, resulting in transovarial transmission. Okay, extrinsic incubation period is 8 to 10 days, and once infected, it remains infective for life. Okay, so transmission cycle: man and Aedes mosquito are the principal reservoirs. So transmission cycle of 4 serotypes do not involve other animals, but 5th serotype follows the sylvatic cycle. And moving on to the pathogenesis, so first there is a primary dengue infection that occurs. So when there is infection for the first time with any one serotype, months to years later, a more severe form of dengue illness may appear called the secondary dengue infection due to infection with another second serotype, which is different from the first serotype, causing the primary infection. Then neutralizing antibodies and non-neutralizing antibodies are formed in response to the infection. So neutralizing antibodies are protective in nature. They are protected or produced against the infective serotype, okay, as well as other serotypes. Non-neutralizing antibodies are produced against the non-infective serotype. Okay, they're produced against other serotypes, but not against the infective serotype. They also last lifelong and are heterotypic. So such antibodies are non-neutralizing, right? So they're produced following the first serotype infection. They bind to a second serotype during secondary infection, but instead of neutralizing it, they protect the second serotype from the host's immune system by inhibiting the B cell activation against the second serotype. So it is called antibody dependent enhancement, ADE. Okay, so non-neutralizing antibodies promote recruitment of mononuclear cells followed by release of cytokines. Among all serotype combinations, antibody-dependent enhancement is remarkably observed when serotype 1 infection is followed by serotype 2, which also claims to be the most severe form of dengue infection. What are the clinical classifications of dengue? So you have the traditional 1997 WHO classification. It divides dengue into 3 clinical stages: dengue fever, dengue hemorrhagic fever, and dengue shock syndrome. Both of these are seen in children less than 12 years of age, mostly. So moving on to the classification, so basically you can see dengue without warning signs, with warning signs, and finally severe dengue. So probable dengue is dengue without warning signs. So what are they? They include travel to an dengue endemic area, nausea, vomiting, rash, aches and pains. Okay, a tourniquet test positive, and leukopenia. Next, warning signs. What are the warning signs? You have abdominal pain or tenderness because of organ impairment, and then persistent vomiting, fluid accumulation, mucosal bleeding, especially liver enlargement, etc. Finally, severe dengue, you can see plasma leakage, which again leads to shock, dengue shock syndrome, or fluid accumulation leading to respiratory distress. Then severe hemorrhage, and also severe organ impairment. So in liver, ALT, AST are elevated, CNS, the consciousness is impaired, etc. Okay. So what are the factors determining the outcome? First, the infecting serotype. Type 2 is more dangerous than other serotypes. Sequence: serotype 1 followed by serotype 2. So serotype, sequence of serotypes, and then age. All age groups are affected equally, but children less than 12 years of age are more prone to develop dengue hemorrhagic fever and dengue shock syndrome. So dengue during pregnancy, perinatal transmission of dengue infection can occur, and peripartum maternal infection can lead to symptomatic infection in the newborn who presents with fever, thrombocytopenia, ascites, or pleural effusions because of fluid plasma leakage, typically during the first week of life. So geographical distribution, so it is tropical to the countries of Southeast Asia and Western Pacific. There is highest risk there. It is endemic in more than 100 countries. Millions of people are at risk. Among 50 million cases of dengue occur every year worldwide. 5 lakh cases proceed to DHF. Now, geographical distribution. In India, it is prevalent in urban cities and towns. In the last decade, every year, greater than 1 lakh cases of dengue were seen, with greater than 200 deaths in India. Maximum deaths were from Karnataka and Gujarat. So all 4 dengue serotypes were isolated, but the 5th one has not been reported yet. Den 1 and Den 2 are widespread. So how do you detect dengue? So NS1 antigen detection. So ELISA and ICT formats are available for detecting NS1 antigen in the serum. It becomes detectable from day 1 of fever, remains positive up to day 18 days, and it is highly specific. It differentiates between flaviviruses. It can also identify the serotypes. So antibody detection, see antigen detection, you are using NS1 antigen. Antibody, you can detect IgM, modati first, right? So from 5 to 90 days. Okay, it is IgG 14 to 21 days, it is low in titers. Secondary infection, IgG antibody titers, they rise rapidly, but it is cross reactive also. It may give false positive result after recent infection or vaccination with yellow fever virus. So in past infection, again, low levels of IgG remain detectable for up to 60 years. So lab diagnosis, you can do antibody detection with ELISA. Okay, IgM antibody capture by ELISA and neutralization tests. And moving on to laboratory diagnosis, you can use virus isolations of mosquito cell lines such as C636 and AP61. Okay, C636. Okay. So molecular method, you can detect specific genes of viral RNA, especially the 3' untranslated region, by real-time RT-PCR and genotype detection. So treatment of dengue, there is no specific antiviral therapy. Treatment is symptomatic and supportive, such as plasma leakage is there, so replace the plasma loss. Electrolyte and metabolic disturbances, correct them, and platelet transfusion if needed. So dengue vaccine, SID TDV. So SID is chimeric yellow fever dengue, and TDV is tetravalent dengue vaccine. It is live attenuated, commercially available as Dengvaxia. So it uses live attenuated yellow fever 17D virus as the vaccine vector. Age is indicated for 9 to 45 years of age. 3 injections of 0.5 ml, 6-month intervals. Okay. And basically, what are the contraindications? So allergic reactions, immunodeficient individuals, and pregnant and breastfeeding women. So WHO recommends to start this vaccine in high burden countries only. So WHO also recommends that Dengvaxia is used only in people who are previously infected with dengue. If it is given to people who have not been previously infected with dengue, they may be at a higher risk of developing severe dengue following a proper infection. Currently, it is approved in Mexico, Philippines, Brazil, Indonesia, Thailand, and Singapore, but in India, it is not yet approved because of safety issues. Now let's move on to chikungunya. It is a re-emerging disease characterized by acute fever with severe arthralgia. So the history, the name itself means something that bends up or gets folded, referring to the stoop posture which develops as a result of the severe joint pain that occurs during the course of illness. So chicken joint pain results in stoop posture, so bending, something that bends or gets folded. So when do you bend? When you do yoga, right? So it belongs to the family Togaviridae of genus Alpha virus, and it is an enveloped virus containing single-stranded RNA. So human transmission occurs by the Aedes mosquito, primarily Aedes aegypti. Rarely there is vertical transmission from mother to fetus or by blood transfusion or organ transplantation. Transmission cycle involves the urban cycle between humans and Aedes aegypti, and also the sylvian or jungle cycle between monkeys and forest species of Aedes. So what are the clinical manifestations? So you have acute and chronic stage. So acute stage, you can see arthritis, obviously chikungunya, chicken joint arthritis. So it is polyarticular, many joints, many small joints of wrists and ankles, migratory and edematous, joint swelling is there. Other symptoms are quite non-specific. You have headache, tenosynovitis, etc. Okay, obviously the joints are affected, the tendons, tenosynovitis. And then chick sign is also seen, chikungunya, chick sign. It is also called browny nose appearance, okay, brownish patchy discoloration or extra pigmentation on the nose. What are the clinical manifestations? Then acute stage, after that you have the chronic stage. Most patients recover within a week, except for the joint pain which lasts for months. So high risk group, newborns, older adults, and persons with comorbid conditions like hypertension, diabetes, or heart disease. Next, moving on to differences between chikungunya and dengue. Remember, in dengue, there is high plasma or fluid loss, right? So what happens is the hematocrit is increased in dengue. Okay, there is minor bleeding which is common in dengue, mucosal bleeding. Okay, hypotension and shock again due to plasma fluid loss, and retroorbital pain is common in dengue. And remember, thrombocytopenia is common in dengue but infrequent in chikungunya, whereas leukopenia is common in chikungunya but infrequent in dengue. Okay, leukopenia, what do you see? Polyarthritis, right? It is more frequent in chikungunya. And then tenosynovitis is common and there is none in dengue. And then rashes appear on day 1 to 4 in chikungunya. C is 3, right? So 1 to 3 days. And then 3 to 7 days, you see rashes in dengue. Fever also again 2 to 3 or 2 to 4 days and 5 to 7 days in dengue. Okay, myalgia is more common in dengue. Okay, joints and tendons are affected in chikungunya. Myalgia is more common in dengue. Okay, remember that. So, chikungunya was first reported in Africa, subsequently introduced into Asia, and caused several outbreaks in various African and Southeast Asian countries. Okay, in India, several outbreaks were reported. And re-emergence was seen in 2005 when it re-emerged in the Reunion Island of the Indian Ocean and affected almost one-third of the country's population. So, following re-emergence, it has been associated with several outbreaks in India, other Southeast Asian and African countries, and it also spread to some areas of America and Europe. The most recent epidemic occurred in Colombia during 2014 and 15. So, in India at present, it is endemic in several states such as Karnataka, Tamil Nadu, Andhra Pradesh, and West Bengal, so South India and West Bengal. Okay, Karnataka accounted for the maximum number of cases, followed by Maharashtra. So, re-emergence, the reasons were believed to be due to a novel mutation in the virus and a change in the vector. So, the new mutation, so alanine is replaced by valine. Okay, so E1, in the E1 glycoprotein gene, 226th position alanine is replaced by valine. Okay, so new vector is Aedes albopictus. So, this mutation led to a shift of vector preference. So, lab diagnosis, viral isolation, mosquito cell lines, it takes 1 to 2 weeks. Serum antibody detection by Mac ELISA. IgM appears first in 4 days of infection and lasts for 3 months. IgG appears late after 2 weeks and lasts for years. So, detection of IgM or a 4-fold rise in IgG titer is more significant. Hematological findings, so you have leukopenia, elevated ESR, and CRP. And then treatment is only by supportive measures. No specific antiviral drugs are available, and vaccine is also not available, although the trials are ongoing. So let's move on to Casanur forest disease, or KFD. So it was identified first in 1957 from monkeys from the Casanur forest in Shimoga district of Karnataka, India. So Karnataka people, they like flavored food. So family Flaviviridae, it is an enveloped virus containing single-stranded RNA. And South Indian teachers, so Karnataka teachers, they put hard ticks on the answer sheet. So vectors are hard ticks. Hosts, obviously, if it was identified from monkeys in a forest, so hosts include monkeys and other animals in the forest, so rodents and squirrels, which maintain the virus through an animal tick cycle, animal and hard tick cycle. Monkeys are the amplifier hosts, where the virus multiplies exponentially. Epidemiology. So KFT is increasingly reported in dry months, so November to June, which coincides with human activity in the forest, and it is endemic in 5 districts of Karnataka: Shimoga, North and South Kannada, Chikmagaluru, and Udupi. So, clinical manifestations, the incubation period varies from 3 to 8 days. The first stage is hemorrhagic fever, and the second stage is meningoencephalitis. So, how do you diagnose it? So, laboratory diagnosis includes virus isolation from blood, IgM antibody detection by ELISA, and nested RT-PCR and real-time RT-PCR. So, treatment is only by supportive measures, and no specific antiviral drugs are available. So, there's a killed vaccine available, so which is a formalin inactivated chick embryo vaccine. It was developed for KFT in Haskine Institute, Mumbai. Schedules are 2 doses at the interval of 2 months, followed by booster doses at 6 to 9 months and every 5 years. Target areas recommended in endemic areas of Karnataka, so villages within 5 kilometers radius of endemic foci. Moving on to other viral hemorrhagic fevers. So first we have filovirus infections. So family Filoviridae contains 2 antigenically distinct genera. So Ebola virus and Marburg virus both cause African hemorrhagic fever. A new one has been recently described, third genus, that is Kiwa virus. So morphology, they are pleomorphic long filamentous threads ranging from 80 to 1000 nanometers, the average size being 805 nanometers in Ebola. So it is highly fatal. Marburg and Ebola viruses have the highest mortality rates. So Ebola virus became a global threat because of its explosive outbreak in 2014, which was declared by the WHO as a public health emergency of international concern. So it appeared first in 1976 in 2 simultaneous African outbreaks occurring in Sudan and Democratic Republic of Congo, or the Czech Republic. So it was isolated. It was the latter outbreak occurred near a village near the Ebola river, from which the virus took its name. So the species, remember, Zaire, Sudan, and rest on Thai forest. So geographical distribution, DRC outbreak. So Democratic Republic of Congo continues to report Ebola outbreaks in recent years. So the most recent being in June 2020. In India, there is no confirmed case documented yet, but the largest outbreak occurred in 2014 to 16, the West African epidemic. 3 primary countries affected were Guinea, Liberia, and Sierra Leone. And reservoir is unknown, but it is suspected to be infected animals, so the fruit bat or primates. So transmission in every outbreak, Ebola virus is introduced to the human population through close contact. So human to human transmission, direct contact, healthcare workers and close contacts, family members of infected individuals, and Ebola virus can stay in the semen for up to 3 months, although sexual transmission has not been reported yet. So what are the clinical manifestations? So you have fever, headache, muscle pain and sore throat, abdominal pain, vomiting, severe watery diarrhea, diffuse erythematous maculopapular rash, petechiae, bruising often leading to shock and death. Mortality, the average case fatality rate is around 50%. So lab diagnosis, serum antibody detection, serum antigen detection by capture ELISA, molecular methods such as RT-PCR, electron microscopy and virus isolation in the Vero cell line. So treatment is by supportive care, rehydration and symptomatic treatment. And no proven treatment or vaccine is available yet. So you need to practice proper infection control and sterilization procedures, and hand hygiene, obviously, wear protective equipment such as PPE, coveralls, N95s, etc. Isolate patients with Ebola from other patients. Avoid direct or indirect contact along with the patient's articles. And avoid attending funerals or wear PPE while attending the funeral of an Ebola patient. If traveling to an Ebola outbreak area, you should be monitored for 21 days after returning. Next, no Ebola vaccine is approved for human use yet. However, several trials are going on. So STRIVE trial is the Sierra Leone trial to introduce a vaccine against Ebola. So the vaccine candidate used here is RVSV Zebos, so recombinant vesicular stomatitis virus, their Ebola virus vaccine. It is currently being used in the 2018 to 19 Ebola outbreak in Democratic Republic of Congo. So the Marburg virus disease, it was first reported in Germany and Yugoslavia among laboratory workers exposed to tissues of African green monkeys imported from Africa. Ever since then, it has been reported in various African countries. So finally, moving on to rodent-borne virus infections. So rodent-borne viruses or roboviruses are transmitted from rodents to man by contact with infected body fluids or excretion. So they are maintained in nature by transmission from rodent to rodent without participation of arthropod vectors. So major ones are Hanta viruses and arena viruses. So Hanta virus belongs to Bunia viridae. Okay, Hanta. Okay, honey, bunny. So Bunia viridae. Morphology, they are spherical enveloped viruses. They contain triple segmented negative sense ssRNA. So clinical manifestations, they cause two categories of manifestations: hemorrhagic fever with renal syndrome and hantavirus pulmonary syndrome. Pulmonary syndrome and hemorrhagic fever with renal syndrome. So epidemiology is worldwide. 1 to 2 lakh cases occur annually. So HFRS is due to Hantan and Dobrava viruses. Hantan, obviously Asia, particularly in China and Korea, and Dobrava sounds Russian, right? So Russia. Pumala virus in Scandinavia and Synnombre virus in America. So hantavirus disease diagnosis is made by detection of viral RNA by RT-PCR. There is no specific antiviral therapy, only supportive treatment is given. Arenavirus infections. Arenaviruses are pleomorphic. They are enveloped with large club-shaped peplomers and contain a segmented ssRNA, 2 segments. So based on geographical distribution, they are grouped into New World viruses. Example, remember Guanarito and Junin. Old World viruses, Lassa virus. Finally, Zika virus disease. It has recently gained attention due to recent large outbreaks that occurred worldwide. So it is an arbovirus, single-stranded RNA virus, belongs to family Flaviviridae, and monkeys are the reservoirs. Okay, so it is primarily transmitted by the Aedes aegypti mosquito. Other modes include mother-to-child transmission, congenital transmission, which is common in the first trimester, rarely through sexual contact, blood transfusion, and organ transplantation. So till date, a total of 87 countries have had evidence of Zika virus infection. So outbreaks have been recorded in Africa, Americas, the Asia Pacific, etc. Largest outbreak recently in Brazil in 2015 to 16. So clinical manifestations. So incubation period, few days to 1 week. So Zika fever, there is fever with rash and conjunctivitis. Congenital Zika syndrome, there is amicrocephaly and other neurological manifestations. So what are the neurological complications? Guillain-Barré syndrome, neuropathy and myelitis. So lab diagnosis. So there is nucleic acid testing. So RT-PCR is the investigation of choice. It can detect the Zika virus single-stranded RNA in the blood and urine up to 1 week. And then IgM antibody detection appears in blood after 1 week of symptoms, remains positive up to several months. And also plaque reduction test. Treatment, there is no effective treatment and no specific vaccine, only symptomatic treatment is available. So fluid replacement and analgesics such as acetaminophen. Though no vaccine has been licensed yet, several trials are going on for Zika virus DNA vaccine and killed Zika virus vaccine. So preventive measures basically control the mosquitoes, and infected patients should prevent mosquito bites for the first week of illness, because then that mosquito can get the infection and it can transmit it to other people it bites. And pregnant women should not travel to areas with Zika virus outbreaks. Sex restriction is also advisable. So CDC recommends condom use or abstinence for 3 months for males and 2 months for females after travel to an area with Zika outbreak.